Welcome to the recorded version of the Grantmakers in Aging web seminar Supporting Family Caregivers, a look at state and national trends, featuring Dr. Susan Reinhardt, Senior Vice President at AARP, Laura Rath, Senior Program Officer with the Archstone Foundation, and John Feather, CEO of Grantmakers in Aging. From January 19, 2016. This event was made possible by a partnership between the John A. Hartford Foundation, Grantmakers in Aging, the Archstone Foundation, AARP, and Grantmakers in Health. Technical and production support is provided by the American Society on Aging.
Well, thanks, Steve, and thanks to everyone for joining us today. This is an important session and obviously a very popular one called Supporting Family Caregivers, a look at state and national trends. As Steve said, I'm John Feather. I'm the CEO of Grantmakers in Aging, and we're delighted to have over 300 of you on the call today. Before we begin, I want to thank the John A. Hartford Foundation, whose continuing support allows us to provide this webinar free of charge for all of our audience. We also want to thank today's co-sponsors, AARP, the Archstone Foundation, and Grantmakers in Health. The profile of the family caregiver in America is changing as the population ages. The new normal of caregiving today includes millennials, people 75 and older, multicultural caregivers, and caregivers who are taking on very high numbers of hours of responsibility. Drawing from a recent report, Caregiving in the U.S. 2015, today's webinar will offer insights on national and state trends and public policy efforts aimed at supporting family caregivers. We'll also learn how a leading funder in aging is seeking to support family caregivers through an array of programs. We're very pleased and honored to have two of the most influential and important voices in this field. Susan Reinhardt is Senior Vice President and Director of the AARP Policy Institute here in Washington, and Laura Rath is the Senior Program Officer with the Archstone Foundation in Long Beach, California. Welcome to you both. Susan, let's start with you.
Thank you so much.
Well, why don't you set the stage for us about the demographic information? Tell us more about what the new normal is and some of the emerging trends that you see in the field.
I would love to do that, and congratulations on having 300 people join this. Of course, this is a subject that I'm passionate about. And with me is Lynn Feinberg, another very passionate person in the field of family caregiving. She currently sits on the IOM committee exploring all of these issues, and so it's really a great honor to be with her and with you to give you some information for some of your thinking for all the people on the phone. So I'm going to lay out a few sort of high points around the research, the literature around this, some of the policy action that's going on. Just to say up front, I'm drawing from many different sources. In particular, the Caregiving in the U.S. study that was released in 2015, along with the National Alliance for Caregiving, which is Gail Hunt's organization. Another one, Valuing the Invaluable, which I'll talk about, really is a look across the field and a meta-analysis of 11 different studies to get us to the numbers that cut across the different studies. And then the Home Alone research that I've conducted with Carol Levine at the United Hospital Fund that gets into some of this higher hour and medical nursing task kind of work. So I just want to lay that out, that this is a lot of work in the field, and give credit to the many people who are contributing to this. So the next slide, please. So setting the stage. Go right on to the next around the financial and demographic imperatives. So this is the Valuing Invaluable. Lynn is a co-author, major author of this study, along with a couple of others here. This is the one that is the meta-analysis, looking across 11 different studies. Well, some of the same studies, but 11 different periods. I'll talk about it. And so in general, in 2013, there are about 40 million family caregivers in the U.S., and we're talking about care provided to an adult with limitations and activities of daily living. This is not including caregiving to children, for example. But it's a pretty consistent number. There are different outliers in different studies, but we feel very comfortable with this about 40 million family caregivers. And looking at what you would need to pay these family caregivers if you were to instead pay for a personal care attendant, say, or a nurse's aide, the estimated economic value is $470 billion in 2013 dollars, and that's up from 2050 just in 2009. And I'd like to say we have state figures on this too. So this information is available on our website at the AARP Public Policy Institute. Next slide, please. So to wrap your head around this $470 billion, which is kind of hard, at least for me, to think in numbers that big, we just provide a few things here, more than all of Medicaid, for example. Family caregiving is, you see that that's the line we're comparing to. I like the top U.S. tech companies. So these are the annual sales of 4 top companies combined: Apple, IBM, Hewlett-Packard, for example, 4 of the top ones, and Walmart. It's more than the annual sales of the largest company in the world. So this is huge numbers. And again, we have them by state also. So the next slide, please. This actually, Lynn Feinberg had a lot to do with this, along with Don Redford, who was here at the time. It's a very simple graph. It's a demographic ratio. We call it the care gap ratio or the caregiver support ratio. I just want to spend a minute on this because this is very useful for the media to understand it, legislators, policymakers. I call it like the sleigh ride down if you just look at this. It's a comparison of those who are turning 45, the boomer generation, we like to say, who are most likely, that's the average, sort of average age of a caregiver, and the boomer generation turning 80, for example. So it's between it's looking at those two groups, 45 to 64, and the boomer generation 80 plus, the adult generation turning 80. If you compare that, I always say we were the best we were going to be a few years ago, 6 years ago, when we were 7 to 1. So 7 potential family caregivers for every older person that might need it. And then if you keep going down, you can just look at all those numbers. 2030, you get to 41. 2050, you get to 3 to 1. We also have this by state also. The numbers vary a little bit if you're in a younger state versus an older state, but generally this is the story, which is saying we have to really put a spotlight on family caregiving, that they're kind of a precious resource and will become even more precious over the coming years. So what can we do to provide the maximum amount of support we can do so they can do their jobs and not give harm to themselves? And we'll talk more about that in a moment. Next slide. See, there's a couple of slides here I've put out here also to just help you through sort of infographics get a concept of what this $470 billion means for 40 million caregivers. So the time commitment, how much time are they putting in? This is, again, across studies. On average, they spend about 18 hours per week. 18 hours per week. You can see 60% are working, employed full or part-time, so this is 18 hours a week on top of a job, and 22% are providing 20 hours or more. We call these the higher hour caregivers, and our last research, the Caregiving in the U.S., the entire study or survey explores the differences between those that are over 21 hours and under 20 hours. And there are major, it's a major look, I think. First time really looking at those that are giving so much of their lives to this, again, most of whom are working. Next slide, please. So here's looking at the work-related. 1 in 4 workers who are 25 years of age are caregivers. So I think of that myself, walking around where I work and sort of 1, 2, 3, 4, that's the one. 1, 2, 3, 4, that's the one. They're all around you. Family caregivers are all ages. They're both genders. They're all cultures. So it is a normative experience now that people are providing care. 72% of workers 40 plus say that they really need workplace flexibility that would really help them balance their work life and their home life. Next slide, please. This is looking at that financial commitment. 7 out of 10 family caregivers use their own money, at least some of their own money, in providing care. And 4 out of 10 say that that really makes them financially strained. This is very hard to capture, to really understand the amount of money they're putting out on a day-to-day basis for supplies, sometimes picking up that copay for medications. There are a lot of different things they're doing that really goes unnoticed, but it's a strain not only on them but for their entire family. Next slide. So that's what we call the new normal. And John, I appreciate it that, next slide, that you were giving a little flavor of that in the introduction. So we always talk about the average caregiver, which, as you know, when you say average, really masks all the variety. But the average is still about the same, 49-year-old female caring for about a 70-year-old relative, typically a mother or a parent, cares for an average of 4 years, spending about 25 hours a week, doing activities of daily living, that is bathing, dressing, helping to eat, mobility, helping toileting, those kinds of things, and instrumental activities, 4 of those, which are more like shopping and cooking and meal preparation, and then medical nursing tasks. I'm going to spend more time in that in a moment, but for now, these are things that typically you think of nurses doing, often in a hospital setting, and it's increasingly happening in the home, and we'll return to that. 60% were providing at least one activity of daily living, known as an ADL. Next slide, please. So here's the millennial caregivers. This was actually quite a surprise for many of us. The study really only looked at a survey of people 18 plus, so we know there are family caregivers that are younger than 18. So this is even a little conservative, you might say. 1 in 4 caregivers is a millennial. That's the ages between the ages of around 18 to 36, 34. So these are fairly young people. The average is 27-year-old, and they're just as likely to be a man or a woman. They are caring typically for a relative, a parent or a grandparent around age 60. They spend 20 hours or more. They're doing both the activities of daily living. They're doing the instrumental activities of daily living. And while it's not noted here, they're also doing these medical nursing tasks. They are employed. Most of them are employed, and they're working about 35 hours each week in addition to their caregiving responsibilities. So this is a group that really needs much more attention. The next slide. We also, for the first time, took a much closer look at caregivers who are age 75 and older, and that's nearly 1 in 10 fall into that category. They are almost 80 years old. They're caring for a peer, someone who's also about 80 years old, typically a husband or wife, a child, a sibling. They're providing care for a long time. These are people who have spent a lot of time, close to 6 years on average. That's an average. And spending 34 hours a week helping, again, on average. They're helping with all of those things, even more than most, and many doing medical nursing tasks. In fact, in a separate study we did in Home Alone, they are doing the most in medical nursing tasks. They are typically the sole unpaid provider. They aren't getting a lot of help from other people, and they're typically living with the caregiver. They also, 73% are communicating with healthcare professionals. This isn't listed on the slide. 70% are managing finances. 55% say they are advocating, and almost half say they have a very high burden of care, and they're more likely to be caring without any help from anybody. I think I mentioned that earlier. So this is an incredibly important group also to be focusing, very high-risk group. Next slide, please. So here's that higher-hour caregivers that this report was the first time that had been coined, actually, higher hour. I know Lynn and I talked intense caregiving. We didn't want to label that like if you go under 20 hours, it's not intense, because any caregiving can be intense. But this is at least 21 hours, and that is 32%. 32% of all caregivers are higher-hour caregivers, and they're providing at least 21 hours of care. But when you look at that 32%, the average is 62.2 hours. So it's huge. It's a huge amount of time that they are spending in this care. Again, they're typically the sole unpaid caregiver. There's a lot of overlap, right, because it's the same sample. They're more likely to be caring for a spouse. 83% of them are performing medical nursing tasks. They are twice as likely to be in a caregiving role for more than 10 years. They often feel that they've had no choice in taking on this caregiving role. And 42% of those that are doing these medical tasks say they've had no preparation, and they're also most likely to have difficulty doing this. They are most often feeling stressed, physical and financial strain, and they're most likely to be saying they're in fair or poor health, and to say caregiving has made their health worse. So I don't have all of that on the PowerPoint, but again, this is a group that we feel we should really give a lot of attention, not to say we shouldn't be paying attention to all caregivers, but those that are really doing this for 20 hours or more a week, we think needs particular attention. Next slide. So emerging trends, you can keep going. We focused on two of this, and this is actually a chapter that I co-wrote with Lynn in a book that was published recently, the growing complexity of family care. So the first trend is that more family caregivers are working. They are juggling the demands of work and caregiving and, of course, everything else you have to deal with in life at the same time. Next slide. So here you can see this hours. If you look at that hours of caregiving per week and the 0 to 20 and the 21 plus, see that pink and the blue? This is an example of one of the charts that we have or tables we have in the report that does that breakdown by hours. And you can see that little asterisk is where there are significant differences. And in this balancing caregiving and work, they are almost all of them significantly different between those that are working under 21 hours or more than 21 hours. So 60% are employed. I said that earlier, at least at some point in the past year. And they are much more likely to report going in late, leaving early. Look at that. 70% have at least some of these situations. Next slide. 70%, I mentioned this earlier, who perform medical nursing tasks reported that doing these tasks, and I'm going to get into that more again in more detail, but 70% say that that is affecting their job. Those who left their jobs, this is what they had to say. 39% quit because they needed more time to be a caregiver. They just couldn't balance it anymore, and they had to pick one or the other, and they chose to quit. 34% also said they quit because they just couldn't get the flexibility. If they could have gotten that flexibility, they might have been able to continue to balance at least for a while. And 11%, that's 2.6 million workers, quit their jobs because they couldn't afford paid care, and there was no one else to do the job. Next slide. So here's that family caregivers doing medical nursing tasks. I wanted to give you a little more detail around that. If you can move to the next slide. This is the report that I referred to. We called it Home Alone because the data show that most people are doing these tasks that we say family caregivers do. I often say that make nursing students get a little shaky when they are first doing them, what they found difficult about it, who trained them, who guided them, and what is the impact on their quality of life. This was the first in-depth national survey. It was released in October of 2012, but it has since been included in different surveys, including our caregiving in the U.S., and so the trends continue, if not pointing to even more of an issue than when we first reported. This is with Carol Levine at the United Hospital Fund. Next slide, please. So complex medications, many different medications. They call that poly medications, meaning it's not just 1 or 2 pills a day. It's many. It could be 14, 20-plus medications. They could be eye drops, ear drops, injections, helping with an IV, many different medications, and that just keeps growing as our armamentum, so to speak, of medications continues. Preparing special food diets, which may not seem like a big deal, but it is huge. I heard a dietitian say there are over 200 special diets now. Just knowing what's in it, where you shop for them, how you cook them, is huge, much more than I even imagined. Wound care, that could include colostomy care or dressings after surgery, all kinds of different wound cares. Changing catheters. This could be Foley catheters. That means a catheter into the bladder, which many people have to have after a spinal cord injury, for example. And there's many, many more not listed here. I didn't want to overwhelm you with a lot of technology, but that's what it is, including lots of different equipment that go right to the home without any explanation, oxygen and feeding tubes and all kinds of things that are happening now. Continue, please. So this is now coming from the caregiving in the U.S., and you'll see that higher hour and lower hour. And this shows, whereas the original Home Alone study said almost half were doing these tasks, this study shows almost 60% are. And some of that is the way you ask the question, but it is clearly a big issue for family caregivers, and that's where it shows the more hours you are giving, the more likely, significantly likely, that you're involved in these tasks. And again, I listed some of theirs, but I also wanted to point out some differences by different cultural and ethnic groups, that Asian Pacific Islanders are also even more so, 37% there, African Americans 39%, and Hispanics. So there is also, we are focusing more on multicultural aspects in these medical nursing tasks, as well as many other differences in family caregiving. Next slide, please. So how can public policy help? Clearly, AARP is very much in this space. It's certainly one of the reasons I came here. And the next slide. I just want to summarize a few of the things that are going on. This is the Assisting Caregivers Today Caucus, the ACT Caucus. This is bicameral and bipartisan, something you can't say a lot about these days, but it is. It was launched almost a year ago, and it serves as a way to get together both sides of Congress, the House and the Senate, and really talk about what ideas there are for these, for solutions and how they might move them along. And so the next slide talks about one of those ideas that has gained some traction. Next slide. And it's called RAISE. Recognize, Assist, Include, Support, and Engage, the RAISE Family Caregivers Act. This is also a bipartisan bill. This is looking at a similar pathway for the Alzheimer's national examination of what's going on inside government across different parts of government, requires development, maintenance, and updating of an integrated national strategy to recognize and support family caregivers by the Health and Human Secretary. This passed the House, the Senate, I'm sorry, passed the Senate and is up for a House vote. And it's looking pretty good. If we can, get them to meet, that would be a good thing. Next. So the respite, the Lifespan Respite Act, it's still currently underfunded, even though it just received an additional $1 million in fiscal year 2016. So now we're up to $3.4 million for 2016. But if you think of 40 million caregivers and $3.4 million, it's really a very small amount. But, we're very happy that it's there, and maybe we can keep growing it to meet the needs. This is to assist family caregivers for respite services, give them a break from their routine and give them a rest, train and recruit respite workers, and trying to enhance more systems that are coordinated for community-based programs. So that's the Lifespan Respite Act. Next. We're also, all of these things on this slide are part of our scorecard, our long-term services and support state scorecard, and lots of other work that is going, not just here at AARP, but in many different collaborators across the country, really. A paid family leave program, family-friendly workplace flexibility progress, trying to expand the reach of the Medical Leave Act, the Family Medical Leave Act, so that it would cover in-laws as well as your parents, grandparents, siblings, other relatives, and go beyond those businesses that are large. So now it applies to large. This would get to smaller businesses, those with fewer than 50 employees. Paid family leave is getting more traction. There are 3 states that have made this a priority, and some activity going on right now at the state level. Access to paid sick days. Well, I should say the other one is more discussion. The sick days is getting more traction. 3 states in D.C., and I know, for example, in New Jersey, which is my home state, there are localities, like 9 municipalities that are passing paid sick leaves. But this is, of course, helpful for people of all ages, whether you are a caregiver or not, and protecting workers with family caregiving responsibilities from discrimination in the workplace. We're tracking all of this on our scorecard, which will be released next year, so we're updating that data now. Next slide. Another thing in our scorecard is looking at delegation. This is active in a couple of states. New Jersey is looking for the governor to sign off on it this month, hopefully within the month. Tennessee, for example, I know is working on this. These are 16 tasks listed here, very similar to the medical nursing tasks I spoke of earlier. But this is to allow a nurse to delegate to a nurse's aide or a frontline worker, a paid person who may be in the home already, and letting them do these kinds of things would allow the family caregiver a break, may not have to rush home from work, for example, which is common. And this has been done in Oregon for, it's close to 40 years now. And so we are tracking this too, and we think this is a priority for a couple of states that AARP state offices are working on. Next slide. You can keep going. The CARE Act, this is very active right now. It's the Caregiver Advise, Record, and Enable Act. This is based on the medical nursing task, based on the Home Alone research, but trying to move some action to deal with that situation that I've already described. And it basically provides three components in a model legislation that states have done, made changes to across the country right now. Opportunity, first of all, every person, regardless of their age, this is not only for older people, but they are asked to identify a family caregiver. Do you have a family caregiver? Of course, they don't ask it in that way, but that's the idea. And do you want that person's name in your health record, your medical record, your hospital record? That's the first one. The second one is that they need, if that person is identified, that person, of course, should be included in the care. That's the goal, patient and family-centered care, and notified of discharge before an hour before, but hopefully 24 hours ahead would be good. And back to the task that they would be offered the opportunity, if they're going to be expected to do these kinds of things, that they would get some teaching and guidance for the family caregiver who's expected to do them. So it's a pretty simple set of legislative requirements in the states that have passed it. So continue, please. This hopefully is giving support to professionals that should be doing this anyway. They typically want to do this, but they haven't really gotten support for doing this or the time to do this. Keep thinking about how to do this. What are some new ways of teaching, how to use technology for that, for example, and clearly it's linked to reducing unnecessary hospital readmissions. Next slide. I know I need to wrap up. I just want to let you know a couple of things. This is the current slide. I think it's updated. There are 19 states and Puerto Rico that have now enacted this legislation. They're not all the same. I have to keep emphasizing that. They vary from state to state, but those general principles are what they're trying to get to. And 20-plus more states are currently working on this in their legislators, so it's very, very active around the country. We are really now thinking a lot about implementation. How are things going to be implemented? What kinds of technical assistance do they need? Can we identify some promising practices so that states don't have to think about this, separately? This is, again, very, very active. Next slide. The Home Alone Alliance, we are just kicking this off. It is, again, based on that research, and it's looking to bring together as many partners that are interested in addressing the general issue of guiding family caregivers through complex care. So these could be funders. There are some funders sitting at the table, for example, foundations, caregiving organizations, the Veterans Administration, scientists that are involved in technology are interested in this. Researchers, a broad coalition. The goal here is for those who think this is a problem and that we should be getting changes, that we develop principles on how you would guide family caregivers in learning these complex tasks, and what kinds of supports can we put in place, beginning with videos. So you can turn to the next one. We are currently working on creating, you can skip that, I already talked about the problem. So go to the next one. So bringing these people together, and there it is, fostering the production of high-quality instructional videos. That's where we're beginning. We have a set almost ready for release on medications, including administration of eye drops and injections. We will see how that goes, and just engaging people and trying to figure out how to improve things. So a major manufacturer, let's say a CVS or a retail store like that, might change the way they interact with family caregivers, or how pharmacists can be engaged in this, and how social service professionals can help get the resources described in better detail for those that are leaving the hospital. So next, please. You can pass that because I already talked about that. I just ketone, but I did want to point out on that. In the end, we're trying to help the family caregiver, and we're trying to change the field. We would like nurses to think about family caregivers in a different way. We would like all professionals to be thinking in a much more proactive, anticipatory, let's not wait to see if they ask us a question. Let's see if we can think of a question they might ask if they knew what to ask, and then do something about it. So that's my contact information and some resources, and I'll turn it back to you, John.
Well, thank you so much, Susan, and thank you for that wonderful presentation. Lots of wonderful material and updating of statistics, and also new ways of looking at this. I'd like to, before we move on to Laura, I want to remind our audience that we will be having a period of time for questions at the end of the presentation, and you can go ahead and start typing your questions in the question box that you see at the right hand side of your screen in the drop-down menu. So please just go ahead and type your questions there, and I will be asking them in a few minutes. So Laura, the Archstone Foundation has responded by funding research and innovative programs to support family members caring for older adults for a long time now. Could you tell us about the Foundation's work, why you're interested in this, and what you see funders in our audience being able to do to help?
Absolutely. Thanks, John. And first, I'd like to add our thanks to Grantmakers in Aging and the John A. Hartford Foundation for hosting us on today's webinar, and to Dr. Susan Reinhard for bringing attention to this important issue and for the valuable information she shared with us. I'm honored to be included in today's presentation, as I know that there are countless members of our audience today certainly better qualified to speak on this subject than I am. Accordingly, it is my hope to use the next 10 minutes or so to share some practical ways in which other funders may incorporate strategies to support caregivers, and to briefly share the approach and interest of Archstone Foundation in this important topic. As my disclaimer, please note that I will speak only to Archstone's specific approach, but during our discussion time and beyond, I would very much enjoy the opportunity to hear how others have crafted programs, policies, and approaches to support family caregivers. Turning to the quote on the next slide, I like to start with this quote that illustrates the great need and importance of caregivers in our society. On a personal note, I am currently a caregiver, also known as mommy, to our two young daughters, although that doesn't include me in the 40 million family caregivers to older adults that Susan referenced. However, my mother, who is a boomer, is currently a caregiver to her mother, who herself is over 80, making this a deeply personal issue. Turning next to the Archstone Foundation. Archstone Foundation is a private grant-making organization whose mission is to contribute to the preparation of society in meeting the needs of an aging population. And this is on the next slide that's presented. Located in Long Beach, California, the foundation awards approximately $4 to $5 million in grants annually. Next slide, please. Archstone Foundation has been funding work in family caregiving for older adults since 1987 and has invested upwards of $10 million supporting a range of efforts, including program development, policy, advocacy, support for the establishment of the National Center on Caregiving, educational conferences, respite services, daycare, support groups, caregiver education, professional education, and more. These are all strategies and program areas where local and national funders may look to add support for family caregivers of older adults. Specifically, I wanted to take a moment to speak about the National Center on Caregiving. Established in 2001 as a program of Family Caregiver Alliance, the National Center on Caregiving works to advance the development of high-quality, cost-effective policies and programs for caregivers in every state in the country. Uniting research, public policy, and services, the National Center serves as a central source of information on caregiving and long-term care issues for policymakers, service providers, media, funders, and family caregivers throughout the country. The National Center on Caregiving is a tremendous resource, and their contact information will be listed in the resource section of this presentation if you're interested in seeking additional information. Moving to the next slide, I wanted to mention briefly that there is a deep intersection between family caregiving and other long-standing priorities of Archstone Foundation, including the Foundation's work in depression in late life, elder abuse and neglect, and palliative care at the end of life. Here I'd like to mention a project supported by Archstone Foundation at USC under the leadership of Dr. Laura Mosqueda, who's currently seeking to educate caregivers, especially caregivers for people with dementia, with the goal of educating caregivers so that they do not engage in abusive behaviors. They're working with focus groups of caregivers and will be translating these materials in both English and Spanish. Turning to the next slide, a current hallmark of the Foundation's work in this area is for support of the Institute of Medicine study on family caregiving for older adults. We're pleased that so many organizations have pooled their resources to support this study, and those organizations are listed here, as well as on the IOM's website. Our hope in supporting this work is that the resulting report may serve as a roadmap for crafting the Foundation's future work in this area and in finding partners or collaborators in government, nonprofits, universities, community-based organizations, advocates, and others. The results of this work is anticipated to be released later this year, and their website also serves as a wonderful resource of information that has been presented during the open sessions of the meetings of the IOM Committee on Family Caregiving for Older Adults. Turning to the next slide, this presents some opportunities for further research and for program innovation. In addition to the anticipated work from the Institute of Medicine, the MetLife Mature Institute and the National Alliance for Caregiving noted these 6 opportunities for further research and program innovation from their Caregiving Research Summit, which was held in June 2007. Next, I'd like to invite those, this is, on the next slide. Additionally, for those planning to attend the Grantmakers in Health annual conference this March in San Diego, I'd like to personally invite you to join us for a breakout session that will be held on family caregiving on March 10th at 11:30. Our hope is to continue this important conversation and specifically brainstorm ways in which funders may collaborate in order to support family caregivers in their communities. Next slide, please. As promised, here are some additional resources and links that were discussed during today's presentation from the National Center on Caregiving, the Institute of Medicine, and the MetLife Mature Institute, and the National Alliance for Caregiving. And on the final slide, here is my contact information. On behalf of Archstone Foundation, I thank you for your time, attention, and interest in today's webinar. And if you are interested in continuing this work and conversation, our door is open and we welcome your call or email. I'd now like to turn it back to John with my thanks.
Well, thank you. Thank you, Laura. That was great, and good to hear some updates about the wonderful work that Archstone has been doing for a long time. Let's turn now to your questions. You can still type them in the question box that you see on the right side of your screen in the drop-down menu. But the first one, Susan, we'll aim this one initially at you. What are the prospects for the United States developing a comprehensive national strategy for caregiving as other countries have done?
That's a really good question, and that's that RAISE Act. So, I mean, we're halfway there. Well, maybe 1/3, right? You have to get through both houses and then the president. So we were delighted that it moved. Again, this is very nonpartisan. You know, just as as Laura just said, there are a lot of people, including those in Congress, are having this experience, or they know, a sister, a mother, or somebody else who's having this experience. So they're getting it more than ever. So I think it's good. I'd give it a good. I don't know, a sure thing, but a good chance.
Well, in this environment, good is better than most of the issues we're dealing with.
There you go.
So, Laura, I'll ask you this question first, and then see what Susan's response would be. But here's a question about working with employers. Has Archstone Foundation reached out to employers to help them to develop either more flexible programs or help them to better understand the issues and so forth? And do you see any role for funders in that particular arena?
Thanks, John. I think that's a great question, and I think something that's certainly very important and needed in terms of reaching out to specific employers. I can't think of any current examples within Archstone's portfolio, but would certainly be happy to update the audience if I am at all misspeaking here. But I think it's an issue area that certainly our board has discussed and has been of interest in terms of how could private philanthropy work with those private companies, private employers, to look at some of those issues and perhaps move the needle in that way to have that outside influence.
Okay. Susan, let's go back to you. This is a question about the reports that you talked about, and asking a question about whether it includes care that's provided for people with developmental disabilities. As you know, that has a couple different aspects. One is many people with developmental disability are now living longer lives, and sort of the special needs that we're coming to understand better for those individuals, but also that many of their lifetime caregivers are now older themselves and are trying to find out how to do that. Do the reports that you talk about have any information about those individuals?
The research that I reported on does not specifically include caregivers of those with developmental disabilities. It is more about physical or cognitive issues, so it doesn't give a specific, I hate to use the word label, but a certain diagnosis, I guess you could say, that way. I myself have studied this issue. I've looked at family care of adults with developmental disability a number of years ago in New Jersey. I know those issues are very real. There are also issues of aging parents, supporting people with behavioral health issues. I have a number of people who I talk to. So we know that there are many different constellations of this. The reports we're talking about, like the RAISE Act, they're not specifically focused on what is the problem of the person that you're dealing with. So I think that's good. It's a little general rather than, just older adults or people with physical disabilities or those who are caring for those with developmental disabilities. This more broad approach seems to be the way we're going. But the RAISE Act is for all ages, as an example.
Okay. I'll address this one to either of you, but it has to do with, it's not necessarily the home alone thing, but boomers alone, in that pointing out that studies have shown that most baby boomers, when asked, say that the people that will care for them and if they have needs in their later life are family members. And yet we know also that boomers are much less likely to have married or to have children. And so it's not clear exactly who it is they may be talking about. So does any of the research or other experience touch on those issues? What about all of those, like you say, who are going to be home alone?
That's why I was showing that care gap, that demographic comparison of those who are 45 to 64 and those who are 80 plus. We are seeing a decline of potential family caregivers for the very reasons you just cited, John. However, we are also looking at friends. When we say family caregivers, we don't just mean blood relatives. We do mean neighbors and friends. And within blood relatives, age peers very often. Not everyone is going to experience functional declines, at least in the same way at the same time. So I'm a visiting nurse by background. I can tell you some of my best memories are those who are caring. I had a group of 5 siblings living together, caring for each other. So there has to be a greater reliance on fewer family members over time, which means that we do need better supports. And it does mean we can't put a family caregiver in a position of you have to leave your job, because they have to be able to take care of themselves and the rest of their family members. Their economic security is affected for the rest of their lives if they do that. So I did like that earlier question, too, about what can foundations do, what can all of us do to help employers get a better handle on this. There is something known as Respect to Caregivers Time, REACT. And that is a group of employers who have come together over the last several years to look at what are some promising practices that employers can put around. Flexibility is the key one. But what else can they do around referrals and support for family caregivers who are trying to balance all of this? We need to help every family caregiver. And I always say, don't expect your kids to be there. So even if you do have kids, don't assume that they are going to be able to do this or live near enough to you to do this, have the capacity to do this. So make a lot of friends.
Yep. And Mrs. Laura, I would add, I think this certainly speaks to the need for an individual approach to each person putting together, what will make most sense and be most supportive for them. I think it also speaks to the issue of family of choice, and people do put together their supports in terms of neighbors, friends, in-laws, just as Susan had mentioned, and it really speaks to and underlines the need for those innovative social supports to be available as well.
Right. And just one last thing, technology is out there. We don't know exactly what that's going to do. There are some ideas on how that can help with activities of daily living, for example, or instrumental activities of daily living. I always say anything that can help reduce those IADLs, instrumental activities of daily living, shopping, cooking, the fact that we were able to have automatic Social Security deposits in someone's bank account relieve family caregivers from having to pick up the check and go to the bank. That seems ages and ages ago, but we need more of that thinking of how to reduce the work that is presented to people.
Absolutely, and I will throw in a personal example of my brother and I are taking care of my mom, who's now in assisted living, and one of the things that's been striking to us is the degree to which sometimes the system is flexible and sometimes it's not. And so, you spend a lot of time trying to convince, for example, the bank that, your relative is in need of some flexibility and what kind of possibilities are. And, the initial response is, I can't talk to you. I don't know who you are. Please go away now.
That's right.
Okay, so where does that leave us?
Yeah. John, I'm really glad you raised that, because we are working on something known as age-friendly banking, and family caregivers factor into that quite a bit. So that what are the products and what is the way to open that door for you and your brother to help your mother and not just have the door slam in your face?
Yes, exactly.
And I would add that certainly needs to be balanced with, I think what their first instinct was, protection of the elder and their finances. You don't want it to cross the line into a financial abuse situation. So these are really complex and important issues.
Absolutely.
So they are. Laura, a question specifically to you about Archstone's, the Archstone Foundation's funding. Do you fund only in the state of California, or is it broader than that?
Oh, that's a great question. So Archstone Foundation primarily funds within the state of California, primarily within Southern California. Some of our initiative-based areas have been on a national basis. For example, the large grant to the Institute of Medicine. But in terms of services and programmatic supports, that's generally limited to California.
All right. Susan, another research question back to you. Are there studies you can point out that look at the correlation between family caregiving and poverty? I assume both poverty, pre-existing, so people with fewer resources have more caregiver stress and so forth, but also the issue about whether caregiving itself causes impoverishment of some families.
No, we don't have any specific studies. I'm looking at Lynn, who's nodding too, that would suggest that caregiving produces poverty. It definitely, as I reported, 40% of those who are helping with providing that kind of financial support say it's straining them. We know that caregivers of all income and education, or family caregivers, come from all ages and incomes. And, of course, any low-income issues around health are already, correlated. Let me put it that way. And if you have to drop out of the workforce early, that can be a cause for poverty down the road. It has long-lasting impact. I recall it was something like 300,000 of assets and income is affected if you drop out of the workforce early. So that's pretty significant.
Right. We're going to have time, I think, just for probably one more question, and then I will turn to both of our guests for their final words to our audience today. And I think the question is on, Susan, could you say a little bit more about the Home Alone Alliance and how you see, if that develops in the way that all of you hope, how do you see that interaction moving forward, and what kind of products and services do you think it can provide in the next few years?
Thank you. Thank you very much, because I'm really just launching this right now. I found that after we released the study, Home Alone, that we would find good examples. That's how I started, good examples of instructional materials or programs or things that existed. And I asked a lot of people, and so did Carol, and we found that there really wasn't anything. And then we had our state offices doing state surveys, and they were finding the same thing. So that's what brought this together. Well, can we bring enough interested parties and different types of organizations to say, we are going to change this situation. When a person goes in the hospital, and the hospital is only one part of that, we realize, but it's a big part of it, because that's often where you get all this stuff to do, these more technical kinds of things to do. But can we get hospitals to think differently? Can we get nurses and doctors and social service professionals, physical therapists, occupational therapists, pharmacists, all of them to have a mind change, a mindset change, that they automatically think for both the patient, the person, and the family caregiver, what are they going to need to do this from now on? Not just this time, but they're going to leave here and they're going to have to handle this most often for many, many, many years. Sometimes maybe it's just a few weeks or a month, but if you have a colostomy, it's going to be that way. So what are they going to do? And we have to change that thinking from this very acute focus to more long-term chronic, not necessarily nursing, long-term care, but longer term. I would like to see when equipment is made, or let's just even take medications, that you don't get that little tiny print that doesn't tell you how to do anything. I'd like it that if somebody goes into a pharmacist and says, I just got this prescription for injections, but I've never been shown to do it, that there's a place for that pharmacist to send them or to show them. That's not what's happening now. Believe me, it's pretty amazing. So I'm really looking for a sea change of how we really interact with family caregivers. They don't know what to ask. What their reports are that they feel not just invisible, but sometimes with hostility. It's pretty profound. If you start asking around, you'll hear this. This is a very common experience. We have to change this caregiver experience to one where they feel really supported, that they feel that people acknowledge this is not easy. This isn't a simple thing to do. You didn't intend to become a nurse, so why don't we do something that can help you take on this job? It's a big cultural change, a big mindset change, too.
Yes, indeed. Well, at this point, I will turn to our guests and ask them for their final words. Laura, why don't we start with you?
Thanks, John. So for my final word, I'd like to say that I hope this is actually the beginning of a conversation and hopefully a beginning for future collaborations. I hope I have the opportunity to meet in person with those of you who are in the audience today, or perhaps have a phone call or email exchange with you so that we can continue to dialogue, brainstorm, and come up with better ways to support family caregivers. So again, I thank you for your time and attention today.
Thanks, Laura. Susan?
Laura hit the nail on the head there. I think time and attention is exactly what we need to these issues, and I like local foundations, for example, people getting together around something that might be solvable, new ideas around that. The CARE Act is one example. There's a lot of activity going on around states. You will see the AARP state offices continuing to make caregiving one of what we call a dashboard goal. So that's a natural ally for those that are interested because they're looking to partner with those that are interested in change. So please feel free to reach out to your state office.
Well, thanks so much. I want to thank Susan Reinhardt, the Senior Vice President and Director of the AARP Public Policy Institute, and Laura Rath, Senior Program Officer at Archstone Foundation in Long Beach, California, for their participation in today's program. We thank you for all you do to make life better for older persons. I also want to thank the John A. Hartford Foundation, AARP, Archstone Foundation, and Grantmakers in Health for their support of today's program. We will be making this presentation available to anyone who wishes to view it later, including both the slides and the audio. Please watch for a rebroadcast link on our website or contact Grantmakers in Aging at info@giaging.org. And finally, I want to thank all of you for participating in today's important webinar. Have a great day.